independently able to adjust it. And that means that we've got to give the parents the skills and potentially the schools and teachers the skills to help children with their exercise and activities. But as they grow up, the range of activities may change, and teenagers' lifestyles are fairly irregular, and you can't really fix a timing or fix anything for them to be rigid. So it's really important for us to understand physiology and for us to then have a grasp of how we fit the regime to the user, rather than for us to have a regime and ask the user to work around our requirements. And that's the only way forward. As you grow older, the challenges are different. For example, for women, if they're planning a pregnancy, or if a lot of my type 1s are into endurance sports and do marathons just to stay fit, and also because as a community, they've come together to connect over these kind of activities. They really shouldn't be missing out on anything because they're on insulin. And it's our job to facilitate it. The second thing is, when we're talking about type 2, it gets a little challenging because our type 2s on insulin are usually more elderly. The tech hacks that we may be able to teach our younger type 1s to use, of course, our type 2s, even the older ones, are pretty tech savvy, but we may need to adapt again to their requirements, their lifestyles. They're certainly more set in their ways, and we need to work around it. So when I say sports and insulin and glucose metabolism, I'm not talking about any one formula, I'm afraid. What I'm trying to do is to give you the skills of basic physiology so that you can go out there and adapt your knowledge to the person who needs that help. So starting with some basics. We think insulin, we think blood glucose. Remember, insulin doesn't only act on blood glucose, nor is blood glucose solely influenced by insulin. In the fasting state, for example, 40% of your blood glucose is through renal gluconeogenesis. We know that the other, nearly 60%, comes from your liver through hepatic gluconeogenesis. In the fed state, the main player for increasing your blood glucose levels is food that you eat. And then there are two burners, if you will, your adipose tissue and your muscle tissue. Now, in early exercise, the muscle tissue comes into play. But later on in exercise, it's your liver and your adipose tissue that come into play. The kidney has very little role to play in terms of glucose and insulin metabolism during exercise. Obviously, the timing of the last meal vis-a-vis the exercise is also a major contributor. So when you think of insulin, yes, it stimulates uptake of glucose into skeletal muscle and fat. But remember, it suppresses hepatic glucose breakdown, glycogen to glucose, glycogenolysis, and it suppresses hepatic gluconeogenesis. And this is why people with type 2 diabetes have that morning spike, because they don't have enough basal insulin to suppress hepatic gluconeogenesis, and also the postprandial spike, because the consequence of having adequate blood glucose should be an automatic hepatic gluconeogenesis suppression with the spike in insulin, but that doesn't happen with type 2 diabetes. But apart from its effect on glucose, remember that insulin increases protein synthesis, especially in muscle tissue, and inhibits proteolysis. So the breakdown of protein to amino acids, which again act as a pathway for gluconeogenesis, is inhibited by insulin. And insulin stops tissue breakdown of triglycerides, lipolysis in the adipose tissue, and increases lipogenesis. So insulin basically helps you lay down fat. But during exercise, again, we want to mobilize fat. So there is a balance that we need to achieve. If you look at the physiology of exercise, a single session of exercise increases your insulin-mediated glucose uptake in the muscle and in the periphery. But more importantly, and especially in early exercise, the non-insulin mediated glucose uptake is the main factor. The other factor is not only is this insulin mediated glucose uptake increased during and immediately after exercise, your insulin sensitivity can be enhanced for 24 to 48 hours after exercise. And what this means is that the tendency to hypoglycemia is much higher. So in someone who's exercising every day, their insulin sensitivity is going to be pretty good. And this is the other reason why we are told never go more than 48 hours without exercise, because depending upon the duration of intensity of exercise, 48 hours is about the maximum before your insulin resistance comes into play again. So this is advice that all of us can take as well from a physiology point of view. So looking at the effects of exercise on glucose uptake and metabolism. Once you start exercising, there is an increase in glucose uptake into the skeletal muscle. This is non-insulin mediated in the first instance. And it is completely independent of insulin signaling. Part of it is because there is vasodilatation and increase in blood flow to the muscle. Part of it is because GLUT4 migrates to the cell surface and helps in internalizing glucose from the bloodstream into the cell. And part of it is because muscle glycolysis and glucose oxidation starts off. The mitochondria go into overdrive. And all of this is even before you do anything with insulin. So the initial response in the muscle is completely independent of insulin signaling. This is why as soon as you start any kind of aerobic exercise, there is an acute blood glucose lowering effect and the blood glucose starts to fall. Now, this isn't true for everything, and that's why I'm going to talk to you about the different kinds of exercise. But this non-insulin mediated uptake is the first response. Obviously, this is then potentiated by the insulin mediated effects. The second thing is, let's go straight to recovery, skipping everything in between, because the everything in between will be the different kinds of exercise. During recovery, there is a gradual decay of muscle contraction mediated glucose uptake. So the muscles calm down and the amount of glucose they take up calms down. Having said that, your counter-regulatory hormones like your cortisol, adrenaline, which have kicked in during exercise, continue. And therefore, there is a risk of hyperglycemia immediately post-exercise. So it's not unusual if somebody exercises and tests their glucose immediately post-exercise, they come to you and say, but I exercised for an hour and my blood glucose is 200 plus. Now, for type 1s, if they're tempted to correct that blood glucose, or even for type 2s on insulin, the consequence will be hypoglycemia. Because if you just leave it alone and come back to it an hour later, depending on the kind of exercise you do, that blood sugar would have calmed down by itself. So the temptation to correct post-exercise hyperglycemia must be resisted, because this is a combination of a slowing down of the muscle glucose uptake and the still persistence of the counter-regulatory hormone response, which then gives you a hyperglycemia, which is short-lived. Now, the second thing is insulin sensitivity in the active muscle is increased, as is whole body insulin sensitivity, and stays increased for up to 48 hours. The other thing is the glucose uptake both in the muscle and in the liver is increased in the post-exercise period for up to 48 hours, because both the muscle and the liver need to replenish their glycogen stores. Now, if this was a marathon, it will take longer. If it was a short sprint, it will take shorter. So depending on the kind of exercise, the risk of hypoglycemia then kicks in. And therefore, post-exercise, regulating the amount of insulin you give patients is really important. And this is why you'll see people who do vigorous exercise in the evening, for example, don't complain of hypos immediately after. They complain of 2 a.m. hypos, 4 a.m. hypos. That's because of this increase in insulin sensitivity, the glucose being shunted for glycogen replacement in the muscle and in the liver, and the consequent hypos. So understanding these basics of what happens short term immediately after you start exercise and what happens after exercise immediately post and eventually post is really important for you to understand the glucose patterns. So seeing a low early in exercise is not dependent on the insulin dose. you need to maybe carb load that individual. So if I see a patient who says 15 minutes into exercise, I get lows, I tell them have a snack 20 minutes before you start exercising. Because remember, that snack needs time to get digested and hit. So for these kind of people, a carb snack 20 minutes before exercise will prevent that, because this is not insulin dependent. Whereas for people like this, who have a high sugar immediately after exercise, please don't tell them to correct it. And for people who have hypoglycemia overnight, well, we need to give them enough carbs to replenish their glucose, but also potentially pull back a little on their basal insulin, not their mealtime, their basal insulin. Now, then there is this concept of the insulin to glucagon ratio. We know that when your blood glucose goes up, your insulin kicks in and your glucagon gets suppressed. This is fundamental. This is part of the dysfunction, especially in type 2 diabetes, this lack of suppression of glucagon. We talked about this right at the beginning when we talked about hepatic gluconeogenesis. This glucagon response, remember, it increases the insulin to glucagon ratio in the portal circulation. And especially if there isn't enough insulin, or if the insulin is appropriately suppressed with insulin, with a lowering of blood glucose with exercise, there is an increased hepatic glucose production both by glycogenolysis and gluconeogenesis. This can prevent hypoglycemia. This is a normal physiological response. The second thing is there is an exercise-mediated sympathetic drive. Remember where I said about your counter-regulatory hormones and increasing your hyperglycemia here? That's partly driven by your sympathetic adrenaline or adrenaline drive. This epinephrine response again prevents hypoglycemia during exercise, may produce transient hyperglycemia immediately after exercise. Both of these are protective. Now, the unfortunate thing is, and therefore, our patients using insulin can potentially have problems down the line. Beg your pardon for a second. I think if my internet connection is unstable, please do give me a shout. I'm just going to give somebody a shout in the meantime to tell them to sort this out. Now, moving on to the next thing. In type 1 and type 2 diabetes treated with insulin, you know that insulin levels don't fall physiologically in response to exercise. Somebody, don't do anything with the internet till my meeting is done. Please don't repair it, don't touch it. Thank you. So, in type 1 and insulin treated type 2 diabetes, so this decrease of insulin inappropriate to change in relation to the change in blood glucose doesn't exist, because there's a depot of basal insulin or a depot of mealtime insulin. And in fact, because of vasodilatation, absorption of exogenous insulin can be increased from exercising muscle, especially if they've injected into their legs and then they're exercising, or if they've injected into their abdomen and they're doing core exercises. I mean, whole body blood supply increases, but especially limbs, if they've injected insulin into their legs, that can cause serious hypo. So you need to be this, and you need to counsel timing of injection and site of injection. Size of insulin unchanged, because remember, the physiological decrease in insulin level does not happen when you have a depot of a basal or a mealtime insulin sitting there. So the insulin concentration plays a role. Site, timing, and dose of the most recent basal and bolus dose of insulin all play a role. So these are all things we need to take into account. Now, before I go on to counter-regulatory hormones, I want to keep this as interactive as possible. Do we have the ability to take questions at present, or would you rather I wait till the end to take questions? Does anyone want to ask me any questions?
Oh, we'll take it at the end.
Moving on then. Let me go back to screen sharing and moving on.
Move back. Unless, okay, I have Ranjit Vasu here. Okay, now Ranjit, can you hear? You have to kind of unmute.
Yes, doctor, I can hear.
Yeah, Usha, Ranjit is a a physical instructor, a trainer, who is basically an engineer who became a trainer. And then, in fact, I've been now asking him to just come to the hospital to know what exactly an exercise is and what is the role and things like that. And Ranjit, would you like to ask any questions from your side? Okay, you are a non-doctor in this group, but from the point of view of exercises, do you have any questions, type 1, type 2, because it was clearly explained? Or if it was too much, then tomorrow when we sit together, we can try to explain.
Yes, doctor, I had one question is in my clients, when I, monitor their CGM, I see that when they go for long walks, right, after their meal, their blood glucose actually, comes down.
We'll come to the type of exercise with relation to the type of the meal, but I may be able to answer your question then. Yeah, go on.
Okay. So with respect to what you've spoken right now, I never understood why, although they're exercising regularly, at around 1:30 a.m. in the morning, I always see a huge spike. And we always tell them that, maybe you should go for a walk after your dinner. But I've noticed even when they do that, the spike still is there. I never understood why that is, because now you spoke about it, doctor, but it just went a little bit over my head.
Okay. So I'm going to cover types of exercise. And if this question is still there by the time I finish my talk, we'll come back to it. Hold that thought. Right.
Okay,
look, the physiology is really important, guys, which is why I'm stopping time to time. If you have questions, if anything is unclear, drop it in the chat box and we'll answer these questions as I go along. Because what I don't want is for me to go through the whole talk and then somebody not understand something fundamental that I could have cleared up somewhere along the way. Right, moving on then. So, are you able to see my screen? Yeah. I'm assuming yes. Okay. So then we come to counter-regulatory hormones. Because remember, we've talked about insulin and to some extent about glucagon. And of course, we know that the timing of the last meal, the type of the last meal affects your blood glucose. But when you're exercising, about an hour into your exercise, and Ranjit, this may partly answer your question, your counter-regulatory hormones, not if it's a short burst of exercise, they will kick in, but they don't have such a sustained effect. And I'll show you some data later. But when you exercise for a prolonged period of time, the muscle glycogen breakdown has happened. The muscle doesn't have much more to give. The liver has started mobilizing the glycogen, but this is being now primarily driven by adrenaline, noradrenaline, growth hormone, and cortisol, not just the glucagon. There is a sustained increase in hepatic glucose output, and then a substrate shift from using glycogen towards lipid oxidation. So when your patients ask you, how much do I need to exercise? The correct answer is anything is better than nothing. But if they really want to burn fat, they need to burn their muscle glycogen, and only then do they start burning fat. Now, where do they replenish their muscle glycogen from? Well, if they're on a healthy eating plan, let's say, some fat depots will get shifted. Remember where I said here there is gluconeogenesis? Where were we? That lipid metabolism. That then goes towards gluconeogenesis and amino acid metabolism. But in the short term, if they really want to burn by using fat for burning, they really need to exercise for over at least half an hour in a continuous stretch, ideally over 45 minutes. Moderate intensity exercise for half an hour still only really metabolizes your initially muscle glycogen and then your liver glycogen stores to start burning that fat. They really need to get into a moderate to higher intensity for at least half an hour, if not more. little bit about glucose metabolism. So I hope that bit is clear. So initially you burn glycogen, then you get your counter-regulatory hormones, then you shift towards lipid oxidation. Now, this Krebs cycle in a simplified form has been the bane of all of our doctors' existences since we did biochemistry. We finished biochemistry, breathed a sigh of relief and thought never again. Well, I'm sorry, here it is again, right? You know this bit. We start with, let's get a pointer up, glycogen, comes to glucose, 1-phosphate, 6-phosphate fructose, goes through the Krebs cycle, and then it gives you ATP. Put that to one side. But other sources, there are various enzymes involved in this. Now, glycogen to glucose 6-phosphate is a two-way street, except in the muscle, because the muscle lacks glucose 6-phosphatase. So once you burn the glucose, muscle glycogen will not get replenished there. So once you're exercising, your glucose goes only one way. You break down your glycogen, it burns. It then eventually gets replenished. But during exercise, muscle glycogen gets burned. Second source of energy, and that's also why you can't do gluconeogenesis in the muscle from amino acids at that time. Second source of energy is triglycerides. Remember, your fat breaks down into triglycerides, which then through the glycerol pathway go into your citric acid cycle, your Krebs pathway, and can be burned to energy. But a byproduct of that is acetyl-CoA to ketones. So ketones in type 1 can, as you know, be dangerous, and therefore withholding insulin for exercising type 1s, just saying, okay, don't inject, go ahead and exercise, may mean that they end up in a decay. Because a corollary of your fatty acid metabolism is an increase in your ketones, and type 1s need their insulin to deal with these. Much less of a danger in your type 2s. Right, moving on. So substrate utilization right at the beginning, as I said, is glycogen. But that glycogen really burns out pretty quickly. Muscle glycogen especially, and eventually hepatic glycogen as well. But in the liver, this glycogen can be replenished on a continuous basis by gluconeogenesis and glycogenesis. The second thing is glucose. Your circulating glucose lasts a little longer. And this is why if you check somewhere around here, you may not have hypoglycemia. But if you check somewhere down the line, because of a combination of peripheral glucose uptake into the muscle, even if they've stopped exercising, but especially if they're continuing to exercise, like for example, a marathon or a prolonged game of football, 90 minutes plus overtime, for example, 2 hours. This is where your patients start getting into hypoglycemia because their circulating glucose level falls. As this glucose level falls, the physiological response would be a clamp down of insulin. But remember, our patients can't regulate that insulin because we put a nice big depot of insulin in their body. And in most of our patients, the counter-regulatory hormone response is impaired. Please remember that. In type 1s and in type 2s, the glucagon counter-regulatory pathway is impaired. And in long-term type 1s and in type 2s who have hypoglycemia unawareness, your epinephrine-norepinephrine pathway can also be impaired. So these two pathways that we talked about initially, which help to prevent hypoglycemia and mobilize glucose, are both impaired in our individuals using insulin. Eventually, your free fatty acids kick in. And this is why I said you really need to exercise for about an hour before you start to see any significant mobilization of your free fatty acids. And this is where you actually start to burn your fat. Now, prolonged exercise, there is a fall in glucose utilization and an increase in free fatty acid utilization. In a type 1 who doesn't have enough basal insulin on board, this is the danger zone where you start generating ketone bodies and they can tip over into decay. Are we clear thus far, or do you want me to ask any? Do you want to ask me any questions before I go on to the next bit? No. Okay, moving on then.
Yeah. Anybody with any questions? I think they can ask, because you people knew you asked for this lecture. I knew this was heavy physiology. So I think it's very essential to know this physiology, because it's the basis of diabetes itself. Okay. So anyway, you all can think about it. If you still don't get it as by the end of it, or you can also send questions to Usha later on. It's not a problem. Usha will move on.
Done. So now remember, as I said, exogenous insulin cannot be shut off. Exogenous insulin, especially the basal component, gives you a prolonged inhibition of hepatic glucose output. And you're increasing your glucose disposal rates because you're burning glucose in the muscle and in the liver. This bit, right? So be very, very, very careful. These are your reasons for hypoglycemia in exercise. And then we come to the types of exercise. Now, I'm talking broadly. If you go to a trainer, they'll throw more lingo at you. But for us doctors, if you understand the basics, we can divide it up into these classes and then manage to a certain extent. And to a large extent, it's individualizing it to the patient. So, number one, aerobic. We all understand that, cardio. Number two, resistance training, HIIT, and low volume training. Now, somebody who goes for a walk in the evening, I would classify as low volume training, unless they're doing it fast enough for it to count as cardio exercise. And the response is going to vary. So, and it also matters whether it is sustained exercise or short bursts of exercise. And this is because your counter-regulatory hormone response might be slightly different. So let's start with the basics. If you do prolonged aerobic exercise, in someone who's unconditioned, glucose goes down like this. With conditioning, glucose takes a more gentle curve, but that's because the muscle has been conditioned. If you're just starting exercise, this is what's going to happen. Okay. Then, in someone who is potentially, let me just shift my banner to the bottom, doing mixed kinds of exercise. So let's say tennis, short burst, but rest between sets. Or football, where you're on the field, but you're running after the ball for some periods of time and you're standing relatively still for some periods of time. Or let's say you're doing societies, for example, now they have leagues, right? People tell me I exercise for an hour, but actually what they're doing is 6 friends are getting together and next time around, you and I play a set, we take a break, somebody else plays, we come back in. So even though they tell me that they're exercising with friends for an hour, when they tell you they're exercising, ask them actually for how much of that period they are physically active. Because if it's intermittent, the intensity and duration can give you different kinds of blood sugar patterns. And in this, the glucose tends to be gentler or may actually even go up in these spurts. And this is why sometimes when you play these kind of sports, you may or may not require glucose, additional dietary glucose at the beginning. But if it's going on for some time, you may need it midway through or in the second half of your exercise period to prevent it immediately post-exercise or later in exercise hypoglycemia. So kids who are playing football plus extra time, I always tell them to take a snack at half time. At that 45-minute kind of interval, have a banana. That works well for them. Now, anaerobic exercise actually shoots your glucose up. So a good way is, for example, to do a load of aerobic, finish with a burst of anaerobic for 90 seconds to 2 minutes. And remember, anaerobic exercise can be weightlifting, can be any kind of resistance training, or can be high intensity aerobic exercise at a spurt. So if they're going to put their treadmill up to an incline of 9, let's say, and then run at 10 to 12 kilometers per hour, that will turn their muscle from aerobic to anaerobic metabolism in their legs and in their lower body. And that might be enough to stop a hypo. So finish your session of cardio with a sprint or with a quick set of rowing or and the incline works because you're doing it as a resistance, because if you're like climbing uphill, or a quick set of weights, rowing, something like that. And that will prevent an immediate post-exercise hypo, not for very long, but potentially enough for them to grab a snack post-exercise. So, moving on. The cases. Now, 32-year-old male, type 1, reasonable control, A1C in the mid-7s, occasional hypos, very hyper-aware. So one would think that, for somebody who's had diabetes for nearly over a decade and a half, not a bad show. Twice daily basal and mealtime insulin. Fasting CBG today happens to be 278. They went out for a party last night, had a good time. He decides, okay, good Lord, I really indulged yesterday. I've woken up at 278. I'm going to go for a 5-kilometer run to burn off yesterday's excess and to bring my blood sugar down. What do we think is going to happen? I want to make this interactive now. People have got to come in and start interacting, please. So tell me, anybody raise your hand, maybe we can unmute, start telling me what we think. Because remember, I've talked to you about the kinds of things that can potentially happen. What do we think is going to happen here? But more importantly, why? I've already put that his post-run CBG was 355. I
think, Satish, you can unmute everybody if you are there as this one, and the participants can actually ask the questions.
Yes, sir. They can unmute themselves, sir.
I can finish this lecture in 20 minutes, or you can make it interactive and we can drag it out for the hour. Choices. Yeah. It depends on how you want to do it. So come in and tell me why the post-run CBG went up.
I think let me ask who is there is.
Can I try, doctor?
Oh, Ranjit wants to try. See now.
Yes, come on then, Ranjit. Perfect.
Come on,
because
Ranjit.
you will be the one counseling your patients. Come on.
So CBG is the blood glucose, right?
Blood glucose. So they've done a finger prick glucose and it's 278, which is high. For a fasting, I'd want my type 1s to wake up 90 to 110, 120 at the most, 80 to 120, let's say broader range. But 278 is very high. As I said, he was at a party last night. He just decides it'll work both ways. I'm going to run it off.
Okay, so after the party, obviously, his stress hormones would be high. And also, if alcohol reduces your sleep, so obviously he's stressed out. Now, in the morning, if he had gone for a 5K walk, his blood glucose would have come down because it would have taken a different pathway. And because he went for a run, which is a little bit more aerobic, therefore his body had to, release the glucose to take care of that aerobic activity.
And therefore,
his glucose went up.
Right? Well done. Congratulations. I think you're halfway there. You're halfway to being an endocrinologist. So, now, why do we think this happened? Precisely because he's on a twice daily basal insulin. Guys, I gave you the clues up here, right? If he injected his basal, let's say 9 o'clock, 10 o'clock last night, then we're at the tail end of the basal insulin, and he's now run for an hour. He's gone from burning glucose to going into his ketone metabolism, and his sugars are high because of his glucose plus the tail end of the insulin plus his kind of exercise. And the danger now is that he's going to tip over into DKA because he's now gone into mobilizing his fats. What are the choices he has? Ideally, he should really have injected a few units to correct that high. And as Ranjit just said, gone for a gentler kind of exercise. He would have injected, waited for it to come down, maybe gone for a walk if he was really keen on doing something to improve his health. So the why is because he's at the tail end of a basal insulin. His sugars are high to start with, and he's now at risk of TKA. Choices: correct, wait, go for a gentler exercise. So 46-year-old female, active lifestyle. I mean, this is somebody who's really trying. She wants to get fit. She's in her 40s. She knows that she needs to be healthy. She does everything. She cycles, she swims, she plays tennis, and still her A1C is above 8 and she has frequent hypos. She's frustrated as anything because with these hypos, she's eating and she's gaining weight. She's trying to eat to prevent hypos, and she just feels that, look, doc, I'm exercising this much, but I have to eat to not go hypo with exercise. And then that defeats the point because I'm not losing weight. So what can you do for her?
Yeah.
This one of the doctors can come. Yeah.
Yes.
Pooja here. Yeah.
Hi.
So basically, she's somebody whose muscles are conditioned because she's very regular with exercises. So there's very high chances of going into hypo in the very few minutes, as you mentioned, the 15-20 minutes of the beginning of the exercise. So she's somebody whom we can counsel to try a snack, as you said.
But
10
she's
or
gaining
20.
weight. But that's
Sorry?
exactly what she's doing. She's eating to prevent hypos and she's gaining weight and she's really not happy.
But is she eating after she gets a hypo? That's the...
She's eating to prevent hypos and she's eating to correct hypos. Anyone else?
And site of injection is another thing. Like we need to ask what kind of specific
She's doing her
muscles.
basals into her thigh and her meal times into her abdomen.
Yeah, then we'll have to ask her to change it to arms.
Do you really think that's which one would you change to the arm?
Bolus?
The bolus from the abdomen to the arm.
No, the thigh to the arm.
She's doing her basal in her thigh and her prandial in her abdomen.
Okay. Then,
but what do you think it'll give you an advantage from changing her basal or any insulin from thigh to arm?
meaning if she's doing cycling,
she cycles, but she also plays tennis and swims.
Yeah, then pretty much all muscles are
but
in action.
Also, I think you need to look up basic insulin physiology, sites of injection and absorption times. That's one for another lesson. Okay.
Yes.
So for this patient, really what you should be asking me is give me more information because you really don't have enough information for you to then adjust her regime. So I'll tell you, she's on a basal and bolus regime.
Okay.
She's injecting her boluses before her meal appropriately and her basal at bedtime. But what you really want to know is then, how do these relate to her exercise? So cycling, she does primarily on weekends. She's part of a cycling club. There are these crazy bunches that start out in the morning at 5 o'clock, 6 o'clock and cycle all the way to Mahabalipuram and have breakfast there. They cycle from OMR to Mahabalipuram and she's getting her hypos after cycling. Tennis, she plays immediately after work, 3-4 times a day, and then comes home. Swimming is mixed. She goes when she has time. So the type and timing of exercise and understanding her routine is really important. So the day she's cycling, she's on a once daily basal. Cut back her basal the night before. This effect of a 50-kilometer cycling is going to last from the Saturday till nearly the Monday. So one, she needs much less basal on Friday, Saturday, even Sunday maybe. Number two, she should be carb loading before she cycles and potentially half, because she's cycling on an empty stomach in the morning at 5-6 o'clock. She probably needs to have a snack periodically through the cycling. Put a CGMS on her, figure out her pattern. Tennis, she's playing in the evening. So the basal is not going to be a major factor, but you might want to look at her lunchtime. I changed her to an ultra short acting lunchtime insulin and asked her to have a snack halfway through her tennis session. Swimming, she swims on the days when she's not cycling, but as a much more gentle exercise. And that's not upsetting her sugars too much, but at night she might have a hypo post swim. So again, cut back on her basal. So you need to understand, because the cycling is the equivalent of a marathon. It's a sustained, prolonged aerobic exercise. Her sugar is going to head down. The tennis is the intermittent spurts kind of exercise. I've told her to have, and this is in the evening before her dinner, too late after her lunch. So she needs a snack. Make her prandial insulin ultra short acting. Give her a snack halfway through her tennis sessions. The swimming is much gentler. Her hypos are post swim and back on her basal. That way, if you understand the physiology of the exercise and the timing of her insulins and the type of insulins, you can then adjust it appropriately. Now, this is a young lady who just got a dog. Previously unused to exercise, started going twice a day for a walk with the dog. She's on a twice daily premix insulin 30/70. Can you tell me what you're seeing and what we need to do? This is your walk example, Ranjit.
Yes, doctor.
So, anyone want to come in?
This is very nice CGM actually. Anyone should be able to comment. Saima, come online.
Yes.
Okay. Your husband works for Novo, so he is a part of a medical team there now. You should be able to answer what's happening now. And the timings are also very clearly given. Hypos at 6 a.m., around 9 o'clock, and again 6 in the evening, 9. Saima, take this question. Are you there?
Yes, sir.
Yeah, take the question. Later on, Kavita can come, or even
Look,
Kirtana.
there are no wrong answers, guys. If you don't ask me now and if you don't discuss it now, the wrong will happen when we are sitting in front of patients.
This
Let's
is
do
like
our discussions now.
because tomorrow these kids with type 1 diabetes, etc., they will come and ask you questions like they play cricket one day, they play football one day in the evening, all in the schools. The day they bowl or bat a lot, they go into hypos and hypers. So I think as doctors, if you are into diabetology, you should know, you should look at it, you should ask questions. Doesn't matter, because we are
And if you don't know the
about
answer, ask me the question.
Yeah.
If you have an inkling, give me an answer or let's discuss. If you don't know the answer, ask me at least the questions based on what you see in front of you.
Saima, ask.
Yes.
Take the question. Take the question. Answer it. Or Pooja can answer. Yeah, Pooja, come online. Or Kirtana.
Ma'am, how do we know, like, so do we presume that she's taking the dog early in the morning for a walk and late evening or evening?
She's going morning and evening.
So
ask me questions. Ask me questions, I'll give you information.
So what, by this graph, how do you guess like what time in the morning and what time in the evening?
I don't guess, I ask her. That's why I'm saying ask me questions. Why should I guess? The
So
patient is sitting in
so what
front of
time?
me.
Because evening, even at 6 there is a hypo. Even almost until 9, her sugars are in between 70 and 80.
Yeah.
So morning again between 6 and 7.
Yes, but ask me the question.
What time is a walk exactly?
Yes, thank you.
Look, Pooja, look at this like this, okay? See, there is an early morning hypo here in this particular case. This could be because of the insulin itself. And then you see a rise in the blood glucose after that. That could be because the patient had a hypo. This could be a rebound phenomenon also, or maybe she had more of thing, or hypo unawareness. She took the dog also for a walk and then there was a rebound. And then again, there is a drop. You see the same pattern in the evening. Now, you as a doctor, you are looking at this pattern. Now, the question is, you have to talk to the patients, try to figure out what is happening, at what time she's taking the dog out, and then how to alter her insulin, how to alter her other things, and how to make her change the treatment. I mean, if it's a girl, taking the dog out for a walk, and if they see somebody like Ranjit going in the road and then showing his muscles, then they may do more walking. So all these questions you should ask.
So, okay, I will just, meaning whatever I
I'm
am
this
thinking.
lady who got the dog. I'm sitting in front of you. What do you want to ask me?
So do you?
I've just got a dog, and I'm
So,
going for walks. I feel super healthy. Except, you know what? I feel awful. I'm not sure why.
My first question to the lady would be, so do you take or eat anything before you take the dog for a walk?
No, I get up at 6 o'clock and go. I feel super healthy.
Okay. So 6 o'clock, she starts walking. And this is the first time ever she started this new routine.
Exactly.
So it is expected for her to feel hypoglycemic, have the hypoglycemic symptoms.
Oh, no, it's not expected. I would hope that we are better doctors than to say to her, you're expected to have hypos.
So yeah, so that is what is happening, and she's coming back home. So post walk, there's a tendency for blood glucose levels to go up. That is what we are seeing at around 8.
Plus, what else is happening there? Dr.
The
Arvind
hepatic-
gave you a clue, and the timing of the day should give you another clue.
Post-exercise
So she's
hypo.
eating something because she did not feel
Having
good.
breakfast, exactly. So
Yeah.
post-exercise, yes, the sugars are going up, but that's also breakfast time. So she's having breakfast.
Yeah, and then she would
She's
have taken
walking
a
on an
morning
empty
dose of
stomach in the
premix.
morning.
Yeah.
She's walking on an empty stomach with the tail end of her premix baser. I told you she's on a 30-70.
37.
Every single sentence has a clue, right? So she's walking on a tail end of her 70. She's walking on an empty stomach. That's causing her 6 a.m. hypo.
Correct.
She's coming home. She's correcting the hypo. She's also having her post-exercise hypo. And she's having her breakfast. So what is happening after breakfast?
So she would have taken a premix insulin pre-breakfast.
Exactly.
And
She's still taking her morning insulin, right?
So the 30 is set in for action. Yeah.
So do you think 30-70 in the morning is a good mix for her?
Not really.
I agree. Because not only is she having hypos pre-meal, the effect of the hypo is going to make her more prone to hypo. Remember that our type 2s on insulin are going to have impaired adrenaline-driven hypoglycemia correction mechanisms are going to be impaired. So, and on top of that, she's having her morning dose of 30-70. So I think she's not on the correct insulin in the morning. And what is the high? What's happening between 11 a.m. and 5 p.m.?
It's going high.
Why do you think that's happening?
That's because the post meal is the 70 is not a good option for her.
That's one possibility.
Rebound
what else do you think might be happening? Sorry?
Rebound hyperglycemia from the
Yes,
hypo.
exactly. Because when you have a hypo, you bounce up. Remember?
Yeah.
So neither is the 30-70 the right mix for her, nor are we preventing hypos, nor are we then be able to treat the consequent highs. So what's happening from 5 o'clock in the evening onwards?
So again, it's the same thing. She's at the tail end of the 70, what she'd taken in the morning.
Exactly. Can I get somebody else to come in? Somebody do the evening segment for me.
Kirtana.
Ma'am, so around 6 o'clock, she's going into hypo again at 6 p.m.
Why do we think that's happening?
She's.
You identified one thing correctly.
Yes, ma'am.
She still has the tail end of that morning 30-70 on board.
Yes, yes.
12 to 16 hours, so that's still there.
Kirtana, you see 2 arrows. There is an arrow in the evening. What is she doing at that time?
She starts walking.
She's going again for walking in the evening.
Yes. There is an arrow. She's walking and then tail end of her insulin, and then she's going
into hypo.
Probably she's not taking a evening snack or something, or she wants to come back and take a snack.
All afternoon, so she's not snacking in the evening. She wants to control her sugars by walking. And do we think 30-70 is a good mix for her in the evening?
No, ma'am. She'll probably do better on a basal.
Agree completely. I think that mealtime insulin is not doing her any favors morning or evening, right?
Mhm.
Ever since she
Yes.
started exercising, her
Mhm.
exercise is taking care of her mealtime requirements more or less. Evening, she's walking her dog before her meal.
Yes.
And then when she's coming home, she's on the lower side. And then she's giving her prandial 30, which means
Yes.
that the first part of the night she's spending in a hypo, barely replenishing her hepatic glucose and her muscle glycogen before off she goes to a walk again in the morning.
Okay.
Yeah. Bad choice of regime for this patient.
Mhm.
So my first choice for her would be to get her off of that mealtime insulin at all. And yes, you're right. A basal insulin might be a better option for her. Maybe even a newer analog that has minimum peaks and minimum potential for hypoglycemia.
Yes.
Everyone agree?
Oh, yes, ma'am.
Yes.
And if with that, the lunchtime highs persist, I might actually put her onto an ultra long acting basal with a short 30, maybe at lunchtime instead of morning or evening. That's maybe where she needs her prandial insulin.
Because there's no much, meaning not much she's doing in the afternoon.
Exactly.
Yes.
So if at all I was to put a prandial, I might put it at lunch for her. Definitely not morning or evening when she's already walking. All of us agree?
Yes.
Yes. Yes.
I think one of the things that we also don't do, Usha, is to check pre and post lunch on a regular basis in our type 2 patients. I think that's another thing we should start, because there's nothing wrong actually in giving a small dose of insulin once a day in the afternoon.
Exactly.
Probably basal at another time. I think it's against convention, so none of us have been doing that. I think we should start doing that.
No, ever since the advent of, well, I don't want to take brand names, but our ultra long acting basal with a small 30 prandial,
yeah,
mostly I use it at lunchtime.
I know, Rizadak.
And I didn't want to talk brands, but yes.
Talk about it. Yeah. Saiba, you go back and then tell Syed that he'll be happy. Rizadak works.
Indeed. So this is what activity does to your blood glucose levels. Anaerobic activity actually sends it up. Mixed aerobic activity tends to hold it stable or maybe raise it a little bit. And sustained aerobic activity sends it down. So over the last sort of 50 minutes, we've looked at our basic physiology of glucose insulin. We've looked at the counter-regulatory hormones. We've looked at the impairment of counter-regulatory hormones in people who are already advanced type 2 on insulin or type 1s on insulin. We've talked about the different kinds of exercise and durations of exercise and their effect on the blood sugar, their effect on the counter-regulatory response, where you shift from glucose to glycogen to fat metabolism, and how in individuals who have a depot of insulin sitting, all of these are affected, right? I'm going to stop here, and we have about 4 minutes left. I'm going to throw it open to questions and discussion, because we can talk, as I say, I can talk about this topic for the next hour if you want. But I think it's time for me to stop and for you guys to start shooting questions at me.
I think I'll start with the first question. Usha, I think what fascinated me when I heard you during the Adore is this is an area that we have totally not looked into, doctors knowing something about exercises and exercise experts knowing about the physiology of insulin and then the carbohydrate metabolism, things like that. We have so many apps and, the patients generally are tuned. So actually from Diabetes India, that is the time I just thought that, actually work with some of the trainers, teach them the effect of the glucose metabolism on exercises, the comorbid conditions that these patients have, effect of different types of exercises on a neuropathic foot, if the doctors are not really doing this work, then the trainer should be in a position to diagnose diabetic neuropathy and advise the right exercise. Otherwise, these patients over 10 years, 15 years, if they have some issues, it will all come on the exercises, because this is an area that has not really worked. I mean, we have worked so much on the medication, so much on the diet, now a lot of things on mental health, but the right exercise for the right patient by the right person. I think this is something that we really need to work. And in fact, we happened to meet Ranjit through some friends, and then in fact I told him, look, you have the base of being an engineer, so language is not a problem. You are an expert in exercise, you have done several courses, but if you can also come and know what diabetes is and what is chronic disease, maybe at some time we should try to bring in the concept of an exercise expert taking a session on what exercises the patient should do. Because everything that you said, if the doctor ends up sitting and talking to the patient,
But I do.
Yeah,
I do.
you
This
do
is
that.
where my time goes. This is why I only give 10, 12 appointments, in a session.
So I think this is a field which we should actually develop with a set of exercise experts, and especially the physiology and physics of somebody with a neuropathy is actually jumping, and then is this one, what exactly is happening to his foot is something. So I mean, that's what I had. In fact, I told Ranjit that, okay, when once you learn a little bit more about diabetes, then maybe a couple of days later, that we have to sit and have sessions and then see how you can talk to the patients and how they appreciate. Of course, we leave it to them. And also, the exercises are so erratic. Of course, your example showed quite a good amount of exercises, but it's so erratic. In fact, my brother goes for golf. And the day he goes for golf, his sugar levels are fantastic. And the day he does not play golf and continues to eat the same amount of food, his sugar goes high. So I think
pump users,
yeah,
I have settings for weekdays, weekends, exercise days, non-exercise days. And technology is amazing. As you said, one, Ranjit mentioned CGMS, right? 2 apps. 3, if all else fails, pumps. And what you can do in terms of setting a pump setting to, in any given pump, you can set 5 profiles at a minimum.
Yeah.
It's amazing. What you can achieve with those settings is amazing.
But unfortunately, majority of our patients, at least my set of patients, find it very difficult to afford a pump. That's one. And 2, I think we must make this, while taking the history itself, I think there must be a paragraph or a few lines written about what exercises does this patient do. And it's very frustrating to know that most of our patients are at least 15, 20 kgs overweight. And that's a kind of weight that they have to lose. And the best of the drugs reduces only 4 or 5 kgs. So this is another thing that we should really work on. And if anybody wants to know what the most updated cricket score is, it's 375 for 7. That's the third one-day cricket match that's happening.
The third ODI, yes.
That's the thing. Okay, if others have the questions, I think they can go ahead and ask questions. I will mute.
Yeah, ma'am, it's Pooja. So regarding type 1s, we had a challenge. So he was going on a marathon and he ended up with fluctuations and hyperglycemia. So is it, meaning especially in the pediatric age group, they are at school the entire day and they're mostly on 3 times or 4 times basal plus bolus. And is there a certain kind of physical activity that would not get their blood sugars to either too low or too high, and it is easier to manage their blood sugar levels with the current regimen that you would recommend?
We should work to the patient. There is absolutely, and I will never advocate for this, that we prescribe something to a type 1 or anyone. Their passion, their interest, their choice of exercise, our knowledge to fit our regime to their requirement.
Makes sense. Yeah. So yeah, so based on the kid's interest, precisely.
Yeah.
I think, Pooja, this is what we have been doing, every time trying to tell them to go for walking, cycling,
Yeah.
skipping, things like that, without even trying to find out what they like. And you try
If
to
you-
tell them something they don't like, they're not going to do it. So they will not
You
exercise.
see my notes within the first paragraph. For every visit, in every visit, you will see the type, duration of exercise, intensity of exercise, incidence of hypoglycemia. You will not see a single, even if the patient comes to me twice a week, you will see this in every single clinical note that I write.
I think you should move over to Bangalore and then join us at Diagnoa.
Doctor, I have a question.
Please set up a collaboration in Chennai. You want a second unit?
Ranjit, you had a question. Yes, Ranjit.
So, doctor, my question was the effect of breathing exercises and yogic poses. What is that effect on blood glucose levels?
Very poorly studied. Not enough data for me to comment one way or the other with any degree of certainty. Whatever little literature exists in this is barely above anecdotal. Someone will say, I've taken 10 patients and done this. That, I'm afraid, does not constitute evidence in medicine. And not for any duration. They'll say, I did 1 session, or they'll say, I did 10 sessions. If you want to do this, then plan it, execute it, get adequate data, which is of a quality enough for us to be able to publish it.
Yes, doctor, because normally when we do high intensity exercise, the body is thrown out of homeostasis, right? But
not really. The body is a beautiful, beautiful, beautiful organ. There is no question of disturbing homeostasis. The very word homeostasis tells you what it is. It is only if you have exogenous drugs, insulin, whatever else on board that you disturb it. But
okay.
But in somebody who's not on anything exogenous, whatever the intensity of exercise you do, your body has a way of, I mean, people live from Antarctica, well, not quite Antarctica maybe, but from sub-Saharan African bush running all day to the Arctic Circle and cope fine, right? I saw Dr. Arvind put in a comment about saying there are postures that improve pain. See, this is what I'm saying, Dr. Arvind. There are small studies, small reports saying that these improve pancreatic beta cell function, but there's nothing that is, see, if I consider something as medical evidence, there needs to be data in a study powered enough to be statistically significant for a duration that's long enough for me to say that this effect is sustained.
Yeah,
I'm sure it exists. I'm not saying that they
correct.
don't. All I'm saying is I don't have the studies to prove it.
Yeah, correct. RSSDI exactly tried to do this. I mean, this was when I was also the president in 2015 and 16. The effect of yoga, and then there were 4 centers, Delhi, Hyderabad, and they miserably failed. And here was a group, PV Rao's group. The teacher used to be there, everyday yoga. They were very dedicated, but it did not show any effect on either improvement of glycemic improvement or beta cell improvement or sensitivity improvement or weight gain. So the final thing was, we're not sure whether it differs from person to person. Is there a body frame which adopts to yoga better? Do we have to look at different categories of people for walking, running, yoga, and maybe mental health? Are we missing out on that? I mean, these things are not clear. And even I think Vivekananda Yoga Kendra people also, they did talk about the good effects of yoga and things like that. But it hasn't really shown consistently. I mean, even in the Western literature, they have tried yoga, especially in Germany. And they really don't know how it works. I mean, it works in some people, not in all.
And I'll tell you one thing. I don't say traditional forms of medicine or alternative. I hate the word alternative because that implies that allopathy is the gold standard, that everything else is an alternative. I don't like that word. I'm not saying that other systems of medicine don't work. What I'm saying is that if they want to be taken seriously by the modern practitioner, they need to generate the evidence, because every other drug that I use, every other intervention that I use, I can support from physiology down to effect, down to consequences. I can connect the dots.
Yeah. I just put up a note because you are a part of the UK diabetes group. So this www.diabetes.co.uk, and especially I think even in the UK, Diabetes UK did a lot of trials and things like that, and they haven't really found anything very useful with yoga compared to the regular.
And they actually support homeopathy on the NHS. Imagine. So look, guys, I've got to run. My take home will be understand the physiology, and if somebody wants to do alternative, other practices, my standard answer to them is it can't harm. Doing yoga is never going to be harmful. It might prove of some benefit, and for you, for any given particular person, it might suit very well. I've had people who've tried everything from Karela juice in the morning to, the banana stem extracts.
Yeah, you continue to do that.
At best, they're getting some multivitamins and some fiber. At worst, you're not doing any harm. So go ahead, do try it.
I mean, instead of doing nothing, I think doing something, a little bit of everything probably, I think is
as long as it's not harmful.
Correct.
If you work with the patient in what they believe, they'll work with you in what you want to bring about as a change.
So thank you so very much, Usha. I know you've taken more than 1 hour and 7 minutes. I think we should have interactive sessions like this. And these are not really the textbook ones that we discussed. I think this is just completely off the textbook and something that's going to be extremely useful. So we'll be requesting you to come out with more things. And then I'm sure Ranjit, one of these days, maybe the basics of exercises and things like that, something like what somebody with heart problem should do, rheumatoid arthritis. I don't want any load on the knees. What do they do? How do they strengthen their back? Because every second, third person has a back problem. And maybe you can help us to demonstrate some of these exercises so that the doctors can learn and then try to teach. And anyway, I will be meeting you in the hospital on days when you said you're free, and then I think we'll take it forward. Thank you so very much, rest of you. And
if
thank
you're
you.
doing that kind of an exercise session, please send me an invite.
Yeah, I mean, Ranjit can directly do it with you also at a time when you are free. That's not a problem. So,
yes, I can.
I think he's a wonderful person. Ranjit, you're married?
Yes, doctor.
Okay, so then you'll have to work around the timing of the family and then how it is and things like that. Thank you. Thank you so very much, Usha.
Thank you.
Just the final thing, I've dropped my email in the chat box. If anyone wants to mail me any follow-up questions, please feel free.
Okay.
Yeah, otherwise your email will be with all of us and Satish and others. So it's not a problem at all.
Excellent.
Okay,
All right.
thank you.
Take care
Thank
and
you,
bye-bye.
Usha. Bye-bye.